Hello everyone at CRISP TV. Today is the first day of the conference CRISP 2025. I'm your host. My name is Dr. Abad Khan. I'm an interventional cardiologist practicing at St. Joseph Hospital, Ghaziabad. With me today we have an exceptional guest and international faculty, Dr. Fabrizio Ugo. He is the director of Hemodynamics unit at Sant'Andrea Hospital in Vercelli, Italy from 2019 till today. He has more than 117 publications to date to his name, and his latest publication on Phenomapping-derived selection of FFR or OCT to personalized percutaneous coronary intervention has been a considerable success and has garnered a lot of attention. Welcome, Dr. Ugo.
Thank you. Thank you very much for your kind invitation and also for your hospitality.
Thank you. And what was the research about? The research you among the so many research you have done, one research where you had OCT and software analysis. Can you brief about the Predict AI machine learning risk model you used in the study?
Yes, it's important because the artificial intelligence growing now for a lot of topic and also especially for us, for cardiology. If you think that in general artificial intelligence will be the future about the check and read very well a chest pain, a chest X-ray, and the CT scan, for example. And now we have an application about the coronary imaging and also physiology. With the new one, Ultron 2.0, for example, we use the new machine provided by Abbott for OCT scanning and total scanning in one single shot of a single vessel. We have a great interpretation provided by artificial intelligence about the calcium distribution, calcium thickness. And in the future, I would like to start in the future to interpret the quality of the light, because now we are able to interpret the calcium, the position, the localization, the thickness, the length for the calcium. But I would like to have the new one that in the future, I think, make possible, I don't know now, but we start in Italy with a new trial named Scalpo that interpret by artificial intelligence the quality of light of the calcium. Because in the nature, we have different kind of calcium.
Yes.
We have the stone, we have the marble, we have different kind of calcium. Also in our coronary artery, we have different kind of calcium. So the next future will be to interpret it, to manage well, to decide also the device on the basis of quality of calcium that we like to treat.
Yes, absolutely. So the risk prediction has to come as the technology progresses, as the AI advancement also comes to the field of interventional cardiology. Dr. Ugo wants to have, is also giving us a foresight as to what he wishes that the imaging should go ahead. Great, so that is a great start. You've also published use of imaging in various coronary complications to use the tricks in LA appendage closure. Also, you were part of a very interesting study actually for STEMI disparities and the outcomes based in Italy, obviously, based on the region. And I really found it very interesting that the data from the symptoms to balloon was 3 hours and which was reduced by the teleporting. Can you just elaborate how does the STEMI care in Italy work after all these advances?
About the ST elevation.
The ST elevation MI.
We have different partners. And
Parts of
endotype of ST elevation myocardial infarction. Today I presented physiology, for example, to study after primary PCI. The patient come in your hospital with ST elevation myocardial infarction. We treat very well with primary PCI. And then we check the physiology, for example, after the primary PCI that was fantastic, your best primary PCI and result. But if you check the alteration, the physiology and impairment of IMR, for example, we can distinguish two endotypes of ST elevation myocardial infarction. One without MR impairment, one other with MR impairment. And that we correlate with the prognosis. And there is an interest study that we have a demonstration that we can discharge the patient the day after your primary PCI if IMR is normal. After primary PCI is crazy, huh?
Yeah.
To understand that. And so I generally I don't use the imaging dedicated to ST elevation myocardial infarction. I use that imaging when we have a failure of a stent. So this is one topic that I dedicated to the imaging. But usually I spend 10 minutes to treat ST elevation myocardial infarction. In my country, in my hospital, we treat 120 myocardial infarction per year. It's a medium number, it's a medium volume for us that we have 300,000 of people that come in our hospital of our region. In total, we perform 1,000 of coronary angiography and 800 of PCI. So there are no normal number. But what is important for the ST elevation myocardial infarction? Just one factor, the time. The time is important. The time that patient come in our hospital. We don't spend more time to check, examine EKG. If you have a diagnosis of ST elevation, you need to come directly on the cath lab.
Perfect. So the technology has advanced. The time has gone by since the standard of care in STEMI was a primary PCI. And despite all the advances, Dr. Ugo still says that time is the most important thing in a STEMI, and that is what can make a difference in the life of the patients. And one more follow-up question to that. Usually we have been seeing that the indices, the physiological indices, have traditionally been told to not been performed at the time of a myocardial infarction. You say that you have been performing the physiological indices at the time of myocardial infarction. So how does this make a difference in via the old protocols and the studies for FFR and the IFR?
During myocardial infarction,
Yes.
we can distinguish ST elevation myocardial infarction or not ST elevation myocardial infarction. If we have a ST elevation myocardial infarction, CFR and IMR impact on the prognosis in terms of recurrent symptoms and angina. But when we speak about not ST elevation myocardial infarction with multivessel disease, for example, we are, with my study, in European guideline for that, to treat not ST elevation myocardial infarction multivessel disease. We performed 10 years ago a trial, a randomized trial about that. The name is SMILE trial, okay? The SMILE trial demonstrates that the treatment of all stenosis is better than culprit-only stenosis.
Yeah.
Why? Because in ST elevation, not ST elevation myocardial infarction, we are not able and found the culprit lesion in 50% of cases. So for that, it's important to revascularize all. Clearly, I don't speak about CTO approach, but if you have 3 vessel disease or 2 vessel disease with 90%, 90%, 90%, I prefer to treat all at the same time and not ST elevation myocardial infarction, because we can lose the real culprit lesion if you treat what do you think is a culprit lesion.
Perfect. Also, please elaborate on your coronary size narrowing improves microcirculation functions in patients with angina. You had a study done. So after you have done a lot of study on these physiological indices and how to treat these angina patients. So these are all forward-looking studies, and the way to find is to improve in the symptoms of these patients. For these atherosclerosis patient or patients who have high indices, do you think are we heading towards newer functional indices with resistance indices also in hindsight now, in foresight now? Newer indices, new functional indices are also upcoming or are planned besides the routine IFR or CFR or the FFR? newer indices in the future do you think that we should come up or we have come up with?
Really, I think that is the future. Now we have the possibility to check that with the Coroventis Coroflow, right?
Yeah.
That I use in the India, I think that come in the next month, right? But in the next future, I think the next 4 years, it, all physiological tests will be made by not invasive, by angiography only. Mu FR or QFR will come in our hospital, in our cath lab, and they have a good correlation with the invasive test. So if you think that the patient come, you perform coronary angiography, you have all data with the coronary angio, because we have all also not coronary angiography, but you have the possibility to have also the physiology provided by only coronary angiography and the software that analyze that, avoiding putting a guide wire. And the coronary narrow, the reducer, we study and we publish of that and this topic in circulation the last year, and then in the next week there will be published my last paper about that. We study physiology with that, and we demonstrated clearly that we have a responder of that in terms of reduction RMR and increase of CFR. We have an impact of prognosis and the quality of symptom and the life of our patients, most important. But in general, I prefer to start with drugs. If I check an impairment of a microvascular dysfunction, I start with drug, and after that, I put a coronary reducer if I don't reach my target and my result.
Perfect. So Dr. Ugo wants to emphasize that maybe less, maybe more, less invasive, maybe the more, and maybe the future of physiological assessment of atherosclerotic coronary artery disease. That is his vision is, and that is his foresight is also like that. Now deviating from functional assessment, latest you have been a big proponent of calcium modification also, and you are going to have a talk also regarding that. Last year after the Eclipse trial, which was presented TCT, what happened to your practice for calcium modification? Did you change or you still believe that the orbital atherectomy will and perform better than balloon angioplasty in some of the scenarios at least?
This is a not easy question because Eclipse don't reach the suspected result that we would like to have about orbital atherectomy. But it's important the selection of the patient. In this case, when we speak about the calcium, is important the selection of the coronary artery, not the patient, but the coronary artery and the calcification of the coronary artery. For example, I mix everything every day, this and every time. This example, when we have incrossable lesion, we cannot use orbital atherectomy. But a lot of people, a lot of our colleagues use the same as a rotational atherectomy. Why? Because in your life you study with a rotational, you came from rotational atherectomy experience. So you came from that. So you are is useful rotational atherectomy than orbital atherectomy, right? In a crossable lesion, you push as a rota.
Yeah.
But it's wrong because you can destroy the coronary artery. You pass from the small orbit to the large orbit and destroy all. And this is one of the point of failure of Eclipse, because they don't select a good patient for that. The selection of the patient is the key of the success. Tomorrow we will present our flowchart, is the most downloaded flowchart in Italy, to approaching the coronary calcification. They use rota, IVL, and orbital also. We need to have 3 devices in our cath lab to have a complete treatment of this problem.
Perfect. So he says that individualization of therapy to each patient, that is most important. One trial failure, maybe the patient selection was not. we should not underestimate the quality of the treatment which has been provided by orbital atherectomy for so many years. One failure, maybe the patient selection was not okay, or maybe we'll have further more trials in orbital atherectomy on more kind of patients, on the patients which the orbital atherectomy works even better. So that is something to look forward to in future. Um, Also, you have come to India for the first time, Dr. Ugo.
This is the second
This is the
time.
second time. How have you been liking Mumbai?
And VAPI for
Yeah.
Merrill Academy, and now is the first time in Mumbai. I would like to have 2 extra day more outside of the Congress, because at the moment, in 1 week in India, I saw only hospital, taxis, and in hotel in Congress.
In Congress, yeah, yeah.
I don't saw India, right? I have to spend more time to visit India and come in another time to visit this fantastic country.
Perfect, perfect, perfect. And also, because you're an Italian, I am assuming you must be a coffee person. Have you tried an Indian tea yet?
No, because I don't like the tea.
I don't like
No,
the tea.
I don't like the tea.
So
I
he
like
does
the
not
fruit.
like the tea, and but he has been a great asset, and he has to start his talk too. And it has been a great pleasure to talk to Dr. Ugo, and we'll see you in the next podcast. Thank you.
Thank you. Thank
Thank
you
you.
very much.
Thank you.
Thank you.
Thank you. Thank you.
Good, right?
Yeah. Oh yeah, for photographs. Yeah, yeah.
Ah, yeah.
इसको रख लो.